So going on to the abstracts, I have no disclosures. So I've just divided them into, there is one on fertility and endocrine decision making. There are two on PROMs, two on toxicity, one on scheduling of pegylated filgrastim, one on preventing trastuzumab related cardiotoxicity. And the last one paper is on using Silicoxib as adjuvant therapy. I think fertility and pregnancy concerns are very important for all our young ladies with breast cancer. And this old study looked at whether this was a concern, and 50% of patients who are younger, most of these patients had breast cancer, 47% in this study, showed that majority of our patients are concerned about fertility. So the decision is between optimizing adjuvant breast cancer treatment or family planning. And as per various previous data, there's 70% lower chance of pregnancy compared to general population in young breast cancer survivors. Coming on to the paper, this is a very nice study from the Dana-Farber group. 643 patients, young women with breast cancer from 13 sites in United States, ER/PR positive, stage 1 to 3 breast cancer. They looked at the impact of fertility concerns on endocrine decision making to see whether this does affect the compliance to endocrine treatment. And they divided the patients as to if the patient chose not to take endocrine treatment, or they chose to take less than 5 years of endocrine treatment because of fertility concern. This was labeled as ET decisions affected by fertility. And those who did not take it at any of the surveys that were taken, they were labeled as non-persistent. 1/3 of the patients had fertility concerns, and this was more likely in those who were younger, other than white, non-Hispanic, those who were unmarried, nulliparous, or had a pre-treatment fertility discussion with a provider. And in the multivariate analysis, being nulliparous was the only factor which was significant. Among women with fertility-related endocrine treatment concerns, 7% actually did not initiate endocrine therapy, and 33% were non-persistent, which is a huge number of patients who did not take endocrine treatment. And we do know that this leads to an overall survival benefit. So I think this is the first study which has truly documented the relationship between fertility concerns, the endocrine treatment use, and pregnancies over time. And it sheds light on the endocrine treatment non-adherence in young women with breast cancer. And we do know that the compliance is a big issue in our ladies with breast cancer. So I think all of us should make sure that all the young women who are of eligible age are counseled about the risks and associated symptoms about chemo-related amenorrhea, premature menopause, and also offered fertility preservation or discussion before starting the planned treatment. And there are various available strategies, which I will not go into, which are available for our patients. Coming on to the next two studies with patient-reported outcome measures, Penelope B study or adjuvant palbociclib study was a negative study, did not show that there was a benefit of giving adjuvant palbociclib in patients with breast cancer, as was the PALACE trial. Both the trials were negative, but if we look at the patient-reported outcome measures in Penelope B, which is really nice to see that the quality of life data is being presented, the authors say that there is actually compared to baseline, there is not much difference in the EORTC QLQ C30 global health scale. But if you see, it is actually significantly worse for placebo, for physical functioning, and fatigue also. But the conclusion, which was presented at ESMO last year, is that the drug palbociclib is easily tolerated and does not affect the quality of life much for the patients. The SOLAR-1 study showed that alpelisib and fulvestrant has a benefit in patients who have PIK3C mutations, and this is currently the standard of care. And the patient-reported outcome measures do show that overall, the author's words are that it does not have much effect on the global health scale because there is not much deviation. But For patients sitting in front of us in the clinic, managing hyperglycemia, diarrhea, loss of appetite, tiredness, we do know that these drugs have a significant effect on their quality of life. So the one thing that stood out was the social functioning, which was worse in alpelisib arm, probably because of due to diarrhea and appetite loss. The negative impact on AE-related symptoms, which was the pain was less in alpelisib, fatigue, loss of appetite was more as expected, diarrhea was more, but these were mitigated in part by delay in disease progression. Coming on to the next two toxicity studies, Monarch E showed us that adjuvant abemaciclib does lead to an invasive disease-free survival benefit in patients with early high-risk breast cancer, and is now approved for use in clinic, irrespective of Ki67. This study looked at venous thromboembolism, elevated aminotransferases, and interstitial lung disease. Most of the toxicities occurred within the first 6 months. If we look at venous thromboembolism, the median time to onset was 6 months. The PE was seen in 27, that is 1% of patients out of 2,791 of those patients who were on abemaciclib. So, and more so in patients who were on tamoxifen. The rise in aminotransferases is again something we do monitor LFT in most of our patients on CDK4/6 inhibitors, especially more so for the first 6 months. And I think this should be continued. Grade 3 toxicities were much less. In 15%, patients had recurrent grade 3 elevation of aminotransferases, but most of these were reversible. Majority were grade 1. If we look at the interstitial lung disease, it was seen in about 0.3 to 0.4%. And again, most occurred in the first 6 months. One should be aware of this. It was higher incidence of interstitial lung disease was seen in Asian patients. This was presented by Dr. Toy at ESMO last year. The second study for which toxicity I'm going to discuss is the Destiny study, which has led to the approval of trastuzumab deruxtecan in third-line setting for patients with HER2-positive breast cancer and has shown a progression-free survival benefit. So I think we were mindful of the toxicity of ILD relating to TDXD in 2019. And I think that led to Dr. Powell and his group colleagues collating all the data together from all the Destiny trials and looking at 245 patients, putting them together to see what the incidence of ILD is in these patients. One must not forget that most of these patients have been very heavily pre-treated, as this has been used in later lines. But we know that the TDXD is being used in the trials are running for earlier lines of treatment as well. The median age of these patients was 56. They looked at various factors, and they especially looked at Japan versus non-Japan. 24% patients were Japanese. Median prior regimens that the patients had received was 7. And if we look at the interstitial lung disease related to trastuzumab deruxtecan, most of the events actually occur within the first year of treatment. If the patients get to that time point. Most of these events are grade 1 to 2. 2.6 patients died out of the 38 patients who had ILD. And the Cox regression model looked at various factors. They put in 13 factors to look at if anything could predict for occurrence of interstitial lung disease. And the only 2 variables which were seen as potential factors of interest were patients treated in Japan versus non-Japan, and those with moderate or severe renal impairment at baseline. So I think we need to be mindful of this drug in patients with renal impairment. So there are guidelines for you to refer to for monitoring of ILD. Again, this applies to all the drugs that we use, including abemaciclib and trastuzumab deruxtecan. Coming to the scheduling of pegylated filgrastim, this is a real-world retrospective study, notes review in 297 patients. It's from Utah, from a US center, presented as a poster. But I think this is very practical because the guidelines recommend that we should give pegylated GCSF 24 to 72 hours later. The aim was to look at the incidence of febrile neutropenia with the same day administration versus the next day administration of PEG GCSF. 64% of patients in this study had a breast cancer. And as you can see, they looked at cycle 1 and all the cycles. And there is absolutely no difference, no major difference in giving the pegylated filgrastim on the same day of chemotherapy. They also looked at those patients with intermediate risk of febrile neutropenia versus high risk of febrile neutropenia, and there is no difference. Preventing trastuzumab-related cardiotoxicity, again, this is very important. This is a randomized trial. Patients receiving anthracycline versus non-anthracycline containing regimen were randomized to placebo, lisinopril 10 milligram, carvedilol 10 milligram. And I think they received, patients with early breast cancer received 1 year of trastuzumab, and they had frequent cardiac monitoring. And the two variables looked at was ejection fraction drop to less than 50% and more than 10% decline in EF. And as you can see, based on all the trials, mainly the HERA trial, which we are actually practicing clinically as well, the incidence of drop in EF was about 4%. But in this study, as you can see, in anthracycline arm, it was about 21%, where EF dropped to less than 50. Overall population, it was about 11%, which was slightly higher than the clinical trials that have been reported. Maybe it's, I think they have not teased into the BMI or the other comorbidities of the patients. And as you can see that the addition of lisinopril does decrease the incidence, does help in preventing the cardiotoxicity. It was about the improvement was not so much with carvedilol as it was with lisinopril. Minimal impact from trastuzumab without prior anthracyclines, as you can see. Anthracyclines prior to trastuzumab caused a decrease to below 50% in larger, as I said, and induced the trastuzumab anthracycline induced decline was prevented with concurrent treatment with lisinopril. So I think this is a very, very eloquent, because we do use ramipril quite frequently in the clinic. The last study is the use of Silicoxib as placebo versus placebo as adjuvant treatment in patients with ER-positive breast cancer. So it is actually HER2-negative breast cancer. 73% patients were ER-PR positive, 27% were triple negative. The primary endpoint was disease-free survival. The patients were randomized to 400 milligrams Silicoxib versus placebo given for 2 years. 72% patients actually completed the allotted 2 years of treatment. We do use Silicoxib quite frequently in our metronomic regimens. And as you can see, despite a lot of preclinical evidence that COX-2 inhibitors do improve the outlook for our patients, this study clearly shows that there is a Silicoxib makes absolutely no difference to disease-free survival. And they also looked at those patients who had Silicoxib high or low, and the Silicoxib 400 milligrams per day did not make any difference to the overall outcomes. I think the key take-homes are oncofertility should be addressed at diagnosis. Whoever sees the patient, whether it's surgical, medical, or radiation oncologist, it should be brought up right at the first consultation at the time of diagnosis so that it avoids delay. PROMs improve outcomes. We need to generate real-world evidence. I slightly disagree with the papers which are presented, which said that it does not affect health-related quality of life. It does affect health-related quality of life for our patients sitting in the clinic. Careful monitoring of patients during follow-up is very important. And lisinopril or ramipril is effective in mitigating trastuzumab-related cardiotoxicity, and I see this as practice changing. Thank you.